It's Dr. Sabrina Siegel here with a special series brought to you by the NEI Podcast. Welcome to the PsychopharmaStahlogy Show. In this special series, Dr. Andrew Cutler interviews Dr. Stephen Stahl on the most controversial, novel, and exciting topics in psychopharmacology today. Every 3 months, we will address a different theme in psychopharmacology. Each theme is split into 3 parts with 1 part released each month. The next theme is on how to effectively manage complex treatment-resistant psychotic disorders. In this theme, we will discuss several books: Treatment-Resistant Psychotic Disorders by Dr. Michael Cummings and Dr. Stephen Stahl, The Clinical Use of Antipsychotic Plasma Levels by Dr. Jonathan Meyer and Dr. Stephen Stahl, and The Clozapine Handbook by Dr. Jonathan Meyer and Dr. Stephen Stahl. Today, Dr. Andy Cutler interviews Dr. Michael Cummings on complex treatment-resistant psychotic disorders. Let's listen in to part 1 of our theme, Managing Complex Treatment-Resistant Psychotic Disorders.
Hello and welcome to another episode of the NEI Podcast series, the PsychopharmaStahlogy Show. And today we're going to be talking about management of complex treatment-resistant psychotic disorders with Dr. Michael Cummings. I'm Dr. Andy Cutler, Chief Medical Officer of NEI, and with us as always is Dr. Stephen Stahl. Steve, how are you today?
I'm just fine, Andy. Great to hear you, and really pleased to see Mike on the line today.
Absolutely. And Dr. Cummings, thank you so much for joining us. How are you today?
Yes, I am pleased to be here. It's very nice to meet you, Dr. Cutler, and it's good to see you again, Steve. I'm pleased to be doing this.
Great. Maybe we can just start out. You guys have written a book, Management of Complex Treatment-Resistant Psychotic Disorders, and it's really something we don't talk about enough. And when I go to meetings, I'm not always hearing about this topic. So what was the inspiration, or what made you guys want to write this book?
Well, essentially, this book was the confluence of 2 influences. One, I'm a psychopharmacology consultant, and I have worked for the California Department of State Hospitals for decades. Steve and I recognized around about 2009, 2010 that the hospitals really provide a 7,000-bed laboratory of serious, severe mental illness. We also realized in our conversations that our patients are not well represented in typical research, that is in evidence-based medicine, because frankly, our patients don't make it into most research studies. They're in the excluded category. And Steve came up, I think, with a very clever observation that although we were practicing based on research evidence, we were also accumulating evidence from our practice, that is practice-based evidence, Steve's phrase, not mine. And that grew into a consultation group called the Psychopharmacology Resource Network, PRN, which we did liberally steal from Pro Renata as needed. The group, under the guidance of myself and Steve, elected to write this book in 2019, and it came to fruition and was published then in 2021.
Oh, I see. During COVID, then, you were writing this.
COVID made an excellent opportunity for writing, and that there's not much to do other than work and go home and write.
Yeah, that's true.
So let me expand a little bit on that. Yeah, Mike's being a little bit modest here. I saw this in many ways as one of the crowning glories of Mike's career, to actually memorialize really what he has done to transform the treatment of resistant psychosis in the state hospital so we could share it outside. And it's exploded. We have peace conferences from the state hospitals to the prison system, to the jail system in California. And then we go to Australia and talk to people. We get consults from other state hospitals on these cases, because as Mike said, there's no roadmap. These patients are not in trials. So there's no evidence-based medicine for them, and the doses and the various tricks of the trade don't work for these patients. So I was so pleased that he would spend the time to actually put this together with our group, and we got it published at Cambridge University Press. It's a way for everybody to understand how you treat these difficult patients and it's going to expand his legacy in this field.
That's certainly a service that you guys have done for our field. And as a clinical trialist who's done a lot of clinical trials in schizophrenia, mostly industry sponsored, I have to agree with you. These patients do not make it into these trials, so we really don't have a very good evidence base. But as you said, you have a very strong practice evidence base. It occurs to me that this book would be a nice companion, Steve, to the other two handbooks that you wrote with Jonathan Meyer, the Clozapine Handbook and the Antipsychotic Plasma Level book. And I'm sure those are both things that are mentioned in your book, in this book.
Yeah, I'll start that. It's basically, Mike can say there's some overlap. The Clozapine book was in much more detail, and the plasma book gives much more of the rationale. But we show plasma levels that you need for drugs. In fact, Mike will tell you that one of the tricks. Do you want to ready? There's a secret. You ready for it? Everybody listening?
Yeah.
A secret.
Yeah.
Turn your headlights on. So if you're driving in the dark and you can't figure out how to treat people because you're in the dark and they're not getting your bed, turn your headlights on. And that means getting a plasma drug level. So I'll let Mike just take it further. But we turn the lights on and it's a magic.
Yes, indeed. Dr. Meyer is actually part of our PRN group. And he and the group basically wrote these three books as companion pieces for each other. The Clozapine Handbook, of course, is everything you wanted to know about clozapine and then some. The Plasma Concentration book is essentially a nice summation of the world's literature on use of antipsychotic blood levels. This book was aimed at giving people three things. The first part approaches strategies for treating these very complex, difficult patients. The middle part is a compressed review of the 85 drugs most commonly used. And then the last part, the appendices, are things that frankly come up as frequently asked questions in our consult service.
It sounds like a great way to organize this. What would you say in patients with complex psychosis, what are some of the most challenging components to treat and how are they addressed in the book?
There are a multitude of them. I often tell our residents and medical students that our modal patient is somebody who had severe childhood adversity, grew up to develop a psychotic disorder, often came from a family of psychotic disorders, which was then complicated by multiple head injuries, substance use disorder, development of a personality disorder. The first thing that we were attracted to in treating this population, largely because we work for state hospitals, was violence and aggression. That essentially is the reason that people wind up in state hospitals. Is it isn't safe for them, either for the patients or for society, for them to be in a less controlled environment until their illness is better managed. The complexity arises both from treatment resistance, and it's been estimated that about 30% of schizophrenia spectrum disorder patients are treatment resistant through current consensus criteria, House et al., which were derived from the Kane criteria. In our hospitals, that number is about 2/3 are treatment resistant. So you have very difficult psychotic illness that is punctuated by a lot of comorbid disorders as well as resistance to treatments that would work much better in the community.
Well, I think you've really elaborated well when you talk about your typical patient, all of the different aspects here to consider. You're talking about, obviously, trauma, life adversity, probably genetics, substance abuse, head injuries, so organic issues, medical issues. It's a lot to sort out, isn't it?
That's an incredible amount to sort out.
What happened is that everybody sees these patients who treat psychosis. But as Mike said, I really like that, his idea that the state hospitals are a vast laboratory. You can be modest and say we don't know anything more than anybody else, but we see it so often that we actually make all the mistakes, figure it out, and then can tell people what to do. But what happens is that it's not evidence-based medicine, it's medicine-based, practice-based evidence. But we've done it over and over again. So many people will see these, but not frequently. We have 40 million people in California. That would be between 400,000 and 800,000 schizophrenics. These would be the 1%. The top 1%, if you will, of the most violent, difficult patients are 7,000 patients in the hospital. We eventually figured out how to do it over and over again. That's what the book's about.
Yeah, I see. Wow. Michael, you mentioned aggression and violence. What are the steps for sorting that out and then managing this in your patients?
Step one is usually the case in medicine is essentially diagnosis, not in this case of their mental disorder, but of the violence itself. That is, what is the origin of their violent behavior? Basically, a group at New York State Hospital nicely figured out that most violence in a state hospital system in a psychotic disorder arise from three sources: the psychosis itself, usually a combination of paranoia and anger, or from associated antisocial behavior. A fair number of our patients are comorbid for antisocial personality disorder, so they may have predatory violence. But a number of our patients, in fact, the majority, 59% of the violent episodes, at least according to one of our colleagues, Dr. Morissette's survey in the state hospital system, 59% were impulsive violence. That is, failure of top-down regulation of violent and aggressive impulses. So the first step is to decide where the violence is coming from, and then to begin to target treatment toward that source. We do the very best, of course, with psychosis because we have good tools. Only 17% of our persisting violence in the state hospitals arises from psychosis because we're good at getting that under control. Predatory violence is mostly an issue for custodial measures, some psychosocial treatments. Impulsive violence is where we really have a long way to go in terms of giving people better control over their impulses. And indeed, we do talk about that in this, as you might guess, with treatment resistance and impulsivity being very prominent issues. We are very pro-Clozapine because indeed it has exhibited both superior antipsychotic effects in a treatment-resistant population and also has demonstrated an ability to improve executive functions and to reduce violence that arises from impulsivity. So we've managed to increase the usage of Clozapine substantially over the last decade. Frankly, clinicians were very fearful of using Clozapine. We've done multiple lecture series, supported people, literally went out and held their hands and said, yes, you can do this. And we've roughly doubled the rate of Clozapine use in the state hospital.
Yeah, I would think, especially in a hospital environment where you have a lot of the supports needed and access to blood drawing and things like that.
Yes.
So I'm surprised to hear there was some reluctance.
If we recommend, and certainly what the literature supports, is that if somebody fails 2 good, solid trials of antipsychotic treatment with antipsychotics from different classes, it's time to move on to Clozapine. Because the odds that person is going to respond to anything else is 5% or less, whereas their odds of responding to Clozapine are somewhere between 40 and 60%. But our average patient who's admitted to the state hospital has had 7.3 medication trials.
Oh my
People
goodness.
stick with what doesn't work because they're fearful of Clozapine.
Yeah. I used to be the medical director of a Clozapine clinic 20 years ago, and I certainly saw for myself what it could do, and the two sides, the good sides and the bad sides of it. But I think on the whole, we'd all agree the benefits outweigh the negatives. What role would LAIs have in this? Would you consider a patient a treatment failure if they have not had a trial of an LAI?
Very frequently, yes. Probably the 2 classes of medication in our population that we push most strongly are Clozapine and long-acting injectable antipsychotics. Even in our setting, the LAIs are underutilized. In fact, that's true of U.S. psychiatry in general. In Europe, the usage rate for LAIs is up around 60%. For people with a schizophrenia spectrum disorder, in the U.S., they're less than 10%. For reasons I don't understand very well, people tend to reserve the LAIs as a treatment of last resort when, frankly, I think we should be using them up front. I know that although every single study out there on adherence says that adherence to antipsychotic medications is miserable, even if you give people full credit for 80% of the doses being taken, compliance rates are still under 40%. But every single psychiatrist tells me, but not my patients. And I tell them, no, your patients cheat on you too.
Yeah. Well, and it's interesting. There is data that if compliance falls below 80%, the risk of relapse starts to go up. So even if you're intermittently compliant, that's a problem. Yeah, I agree with you. I feel like you can't really tell that someone's an atypical antipsychotic until they've had a trial of an LAI. And I have some somewhat good news, Michael. The latest data I saw is maybe 10 to 15% of patients are now managed in the U.S. We've had We've had a number of companies, as you know, promoting and educating. And, I like to say for some reason, most of us are trained that you have to earn an LAI by being non-adherent and relapsing. And that just doesn't make sense to me either.
Yeah, whereas if you read this book and some of the articles that we've also published, we suggest that LAIs should be very high up, very early in treatment.
There's evolving data from studies that show, guess what? If you don't treat people, they don't get well. And if you don't treat them and they relapse, they have bad outcomes. And if you don't treat them and they relapse, then you get treatment resistance. And so we have a number of decriminalization programs. And in California, this new CARES court, which is a way to divert people who haven't committed a crime yet into treatment. If you don't treat cancer at stage 1, it becomes stage 4. If you don't treat psychosis at stage 1, it becomes stage 4. That's the violent 7,000 patients that we have in the hospital. So how do you treat them? It's with the LAIs, particularly after they leave the hospital.
Yeah, I had a professor in my residency who used to say, never let a patient stay psychotic because psychosis is bad for the brain, which has always stuck with me.
Very, very true. I was impressed in looking at the imaging literature that obviously after a first break, the response to an antipsychotic is typically wonderful, greater than 90% response rate. By 5 years after onset of illness, that's typically down around 50%. Wow. And that seems to be correlated with, frankly, loss of brain. People who have recurring relapses during the first 5 years of illness lose about 2% of their brain every year. And that's brain that's gone. And I think that shows up. The other statistic that has really stuck with me was a study by Tohanen et al. In Sweden, where they compared LAIs to the same medication, its oral counterpart. The nice thing about the Scandinavian countries is they track people from birth to death. And they found out that the people on LAIs live 30% longer.
Oh my goodness. That's remarkable.
Which is, if I told most people, if you take this medicine, you'll live 30% longer, well, that's a pretty good ad.
That's pretty good. Yeah, his group also has data on decreased hospitalization rates, relapse rates, and a number of other positive outcomes. So I think now the standard of care, the evolving literature really suggests, exactly as you're saying, that we should be using LAIs earlier in our algorithms and give people the best chance. So that's definitely one of the tricks here. You talked about managing aggression. I want to go back to that for a second. Some of us think about using anticonvulsants for impulsivity and aggression. Is there a role for those?
There is, and indeed that's addressed both in terms of an approach to aggression and impulsivity, particularly early in the course of an episode of psychotic exacerbation. In particular, we use a lot of valproic acid. It seems to have a great deal of applicability, particularly in the early days of a psychotic relapse, for decreasing psychomotor agitation and violence. Becomes less important in people without an affective component as the antipsychotics take effect. Lithium also, although lithium's formal data is mixed with respect to pure schizophrenia, but when there is a mood component, which is frankly not unusual in our patients, a large number of our patients are vulnerable to a bipolar diathesis, then lithium and valproic acid become incredibly important. We use very little carbamazepine, the other first-line mood stabilizer, largely because of problems with its side effect profile and, of course, its hepatic induction.
Of course. Yeah, I was going to ask about lithium, so I'm glad you mentioned that, too. I used to use lithium with Clozapine when I was running that clinic frequently. Not infrequently, I should say.
We do as well. For lithium, of course, has a specific indication for, aside from mood stabilization, for decreasing suicide risk, but one of our most common uses is to boost the person's absolute neutrophil count. And where we see it used in one of the pieces of advice in the book is in the chapter on treatment-resistant psychosis, is to use it for those people who keep slipping just below the threshold, and then they wind up with 3 times a week blood monitoring, which frankly over time that will cause people to not want to take clozapine. So we give them lithium to see if we can get them up above that threshold so that doesn't keep happening to them.
We're talking about assessing and managing agitation and violence. Are there specific parts of the brain involved? Are there circuits involved? You mentioned a failure of top-down regulation, but could you get a little more specific?
Yes. In terms of particularly in the psychotic person who is paranoid, it doesn't appear to be the paranoia per se that causes the violence. It's paranoia coupled with anger. Leslie Citrome has made that argument very effectively. In this case, the lateral basal amygdala in the temporal lobe sits there looking at the environment saying, what's dangerous, what's going to get me? When it sees something dangerous, whether that's real or not, it sets off the fight-flight response, which then you get the alarm bells go off in the limbic system. And in the healthy brain, the person may be able to use their prefrontal cortex to suppress that response and go, look, okay, this really isn't that dangerous. Most of our patients can't do that. So they have a limbic firestorm, wants to set off a fight-flight response, and the frontal cortex doesn't tell them this is not a good idea. And that results in violence related to paranoia. Now, the impulsive violence in some ways is similar in that all of us have impulses. One of the things I tell people is the last guy who cut you off on the freeway, what was the thought that went through your mind?
Yeah.
But your frontal lobe, your frontal cortex said, no, that's not a good idea. Don't do that. In fact, our frontal cortex spends most of its time going, don't do that. Don't do that. Oh, really? Don't do that. And then every now and then it'll go, that one's okay. Go ahead. For our people, frequently they can't give that no response. There are bad consequences that will result. And there's some evidence that in those who are prone to phasic firing of the ventral tegmentum in terms of dopamine, that can actually get transferred to the dorsal striatum where it becomes essentially a compulsive response. And those are our most difficult patients because when something in the environment triggers them, somebody offends them or somebody disrespects them, between their dorsal striatum and the behavioral response, there's virtually no room for thought. It's basically essentially a reflexive response at that point. The only thing in those patients I've seen, 2 things. Clozapine works by increasing executive functioning, so the frontal cortex has a little bit of a chance. The other thing that has worked in people whose psychosis is very well controlled, their D2 receptors have been tamed in their limbic lobe. We've actually used things such as alpha-2 agonists to decrease norepinephrine influence. We've used dopamine stimulants, albeit very carefully, usually a controlled release formulation.
Say that again. Nobody's going to do that, Dr. Cummings.
Yeah, it's counterintuitive.
Give me a break.
Sorry, we did it and we published it. What can I say? We're fearless.
Yes, we did. It's amazing.
And we found it worked. And we had patients whose psychosis was under control, but they could not overcome their impulsive violence. We put them on very modest doses, usually of methylphenidate extended release. Now, this was a case series, so we're not talking controlled data. But in 6 out of 6 patients, they went from being violent to, in 4 out of the 6 cases, being discharged.
My goodness. It makes sense. If you've got an antipsychotic on board, you've got the ceiling on board, you've got the limbic system capped, if you will. And now it sounds like you're increasing dopamine to the prefrontal cortex. That's what we do when we treat ADHD, for instance.
Yes, exactly. If you can tame the D2 receptors, that leaves the D1 receptors in the frontal lobe open to be influenced. And that's essentially was our rationale, our target for trying, as Steve says, this rather dangerous thing.
Certainly in the bipolar literature now, there's a couple of large meta-analyses, one of them from Sweden, again, a Scandinavian country, that if you have somebody adequately mood stabilized, adding a stimulant is not only not dangerous, it's a good thing to do. It improves mood, impulsivity, cognition, and so on. And I would assume the same is true here. So
yes, essentially we're looking at the same model where the limbic and ventral tegmentum areas have been tamed. They're behaving themselves. And we can now wake up that hypoactive, under-functioning prefrontal ventral medial cortex.
Yeah, really fascinating. Hopefully people who are listening here aren't shutting us off at this point thinking we're quacks, but I hope they're going to listen here.
I would add the caveat to this that people must do this very carefully in a controlled environment and only in people whose psychosis is well controlled.
Well said. Yeah. I mean, in the outpatient world, you have to be careful that the patient doesn't stop the antipsychotic and continue the stimulant, of course.
Yes.
And people who have active substance abuse issues and so on. All right. We've been talking about how to maximize atypical antipsychotics. Let's go back over to plasma drug levels for just a second. First of all, Steve, I think, mentioned why it's so important to measure these levels. You need your headlights on. You got to see where you're going. And what are some of the principles that we should know about when checking levels?
Yes, indeed. Physicians, psychiatrists have relied on dosing forever. Doses, however, are a very imprecise way to judge whether you're providing adequate treatment, and particularly with the antipsychotic.
It's not about what's in your mouth, it's what's in your brain?
Yeah, guess what? Isn't that such a strange thing? We now have fairly reliable plasma concentration curves and receptor occupancy curves for the antipsychotics. And of course, the first use we put these to is to ask the question, is the person actually taking the medication? Because if you're seeing variations from measurement to measurement of greater than 50%, the odds are the person is intermittently taking the drug. You can also have people who you give them a drug that you would expect to work and you're not seeing anything. No side effects, no benefit. Well, plasma level can help you there because they may be a rapid metabolizer of that drug and there may not indeed be any. Most flagrant example I have of that, it was a gentleman who was compliant with medication. We knew that from other medicines he was taking. His psychosis wasn't being controlled by haloperidol, 60 milligrams a day. We measured his plasma concentration. It was less than 2 nanograms per mil. It got to his liver, and that's as far as it got. In his case, switching him to a different antipsychotic, and lo and behold, his psychosis got better. And of course, the other way, if you put people on a drug and they develop all sorts of side effects, and you may find out they're a slow metabolizer. They've got a gigantic plasma concentration. And then one that people sometimes don't think about is the person responds to your treatment. They look absolutely perfect. That's a great time to benchmark how much of that drug did that. So that if it later changes, you can come back and say, I know how much they need. Because the dose it takes to achieve that may change.
It is true that we've all been taught that using antipsychotic plasma levels generally is not useful. Antidepressant levels not useful. Don't do it. Because if you look at the scattergram, I'm sure Eddie's seen these of after you do a clinical trial, all the people who got better, their plasma levels are all over the map. And that is true, but it's, you'd say, true and related. What we're talking about is iterative use of a plasma antipsychotic level in a treatment-resistant patient, not all comers, and do it iteratively. In other words, following it over time. If it's 0 or low, you got a diagnosis. If it's off the scale high, you got a diagnosis. But if it's not high enough, despite dosing, then you increase the dose and check the level again in that same patient. And that's where it's most useful, is iterative use over time within a patient who's not doing well. It's very useful then.
Yeah. The corollary reason we do this is we've been trying to educate people about structuring their medication trials. People sometimes have a bad habit of, let's give this person 5 medications all at once and we won't measure anything and we'll just see what happens. What we try to get people to do is pick your best medicine, get them up to at least a minimum response threshold, which means measuring it, of course. Minimum response threshold doesn't mean they will respond at that level. And then if they're not showing intolerable side effects, you titrate up. And you keep going until you reach one of 3 endpoints. The person gets better. Great, you stop. The person develops intolerable side effects. Well, it's the end of that trial if you can't fix it. or you reach the point of futility where their odds of response at higher concentrations is less than 5%. If you do that iteratively, as Steve's suggesting, what kind of trial you've had, you know whether it was a success or a failure. When you just randomly change things, no matter what happens, you can't pin down what caused it.
Yeah. Yeah, you're reminding me vividly of a patient I had when I was running the Clozapine clinic who was on quite high doses. He had schizoaffective disorder, bipolar type. He was on high doses of Clozapine and of valproic acid, very high doses, and was still experiencing psychotic symptoms. And I did something crazy at the time. I checked levels of both of them. And this guy was in a supervised setting. I know he was compliant, and his levels were low. And I raised the dose. He was obviously a fast metabolizer. And he came in the next visit doing great. The people at his group home thanked me for being such a cowboy because I was way above the recommended doses here.
Well, you got a manual to being a cowboy. They've got guides for cowboys and teasing because it isn't a cowboy when you do it that way. But you need to have a context of this, and there's some guidance and some guardrails, and they really work if you do that.
Yeah, certainly agree. I think it is clearly an underutilized tool in our armamentarium.
Keeping up with the latest in psychiatry shouldn't be a struggle. SynovianFieldMedical.com is a new website for clinicians where you can find a library of free, hand-selected resources, such as videos and infographics on important psychiatry topics. You can request an educational program for your practice or connect with Synovian medical professionals in your area. Synovian wants to help you get all of your psychiatry questions answered. Go to SynovianFieldMedical.com and explore what Synovian has to offer.
Okay, let's talk now a little bit about combinations of antipsychotics, all right? I know that literature is not great on this, but yet we do it. What is the rational kind of thinking about combination antipsychotics?
Yeah, and we do address this in the book. There are two types of polypharmacy. There's irrational,
right?
Where basically you're giving two medications that do exactly the same thing. That makes very little sense. Just give the person more of one. For example, if were you to combine haloperidol and fluphenazine, you have D2 blockade and D2 blockade. It doesn't make any sense.
Or risperidone and paliperidone would be another irrational.
Yes, trust me, I've seen that one. What does make sense is when you choose medications for polypharmacy based on differing mechanism of action. For example, we don't know for sure, that clozapine provides the bulk of its benefit by modulating glutamate. It may also be by modulating M4 muscarinic receptors. It may have some other effects that we don't even know about yet. Yes, perhaps TAR1 as well. But anyway, none of those has anything to do directly with modulating D2 at the D2 receptor. Clozapine plus a partial agonist or dopamine plus a dopamine antagonist may be a rational combination for some patients. And indeed, the one that's best supported in the literature currently is clozapine plus aripiprazole for those people who have persisting negative symptoms, despite the clozapine having fixed their positive symptoms. We also do have a few people in our experience who respond well to clozapine plus a D2 antagonist when they have residual positive symptoms, although the literature suggests that is a positive finding. Usually the effect size is small, 0.2, 0.3. So add-on dopamine antagonists should not be expected to produce huge changes. One other thing we promote as an adjunct to clozapine very frequently is electroconvulsive therapy, because it actually produces benefits in the moderate range.
I think that's a very underutilized modality too. I agree.
Yeah, and in fact, I and one of my colleagues, Jennifer O'Day, recently wrote an editorial for CNS Spectrums for Steve, essentially defending ECT against those who would want to see ECT abolished.
It's a secret weapon. And again, this is for exceptional cases. This is not first-line treatment, but boy, is it important to have in the armamentarium.
Yeah, completely agree. Okay, one of the most common combinations I see is any antipsychotic plus quetiapine, which I suppose people are using it for the associated symptoms, insomnia, anxiety, and so on.
They're essentially using it as an antihistamine, which I agree. Quetiapine is a very potent antihistamine. It's a very poor antipsychotic when you look at most of the rank ordering of antipsychotics, and I'm thinking of Lucht et al. Or some of Carell's work. It always comes out near the bottom of the list. Frankly, we tend to favor use of hydroxyzine because it doesn't come with alpha blockade. It's not anticholinergic. In other words, we're using it for the same purpose. It blocks histamine receptors, but it doesn't do all these other things that you may not want.
The other thing that quetiapine brings to the table, it's probably the most effective antidepressant of the atypical antipsychotics, has a very strong antidepressant signal. So perhaps in that setting, it makes sense. But yeah, you're clearly right.
Yeah, we use quite a bit of it in the context of bipolar depression in particular, since the number of tools we have for bipolar depression is limited because, frankly, one of the other themes you'll find in this book is telling people if you have a patient who's vulnerable to a bipolar diathesis, even if they are depressed, do not give them a classic antidepressant. Because
say more about that.
A number of studies since 2007, there was a New England Journal of Medicine article that reviewed the effects of giving a mood stabilizer plus either bupropion or I believe it was fluoxetine to people with bipolar depression. The people on the mood stabilizer alone got better faster.
Yeah, you might be talking about Gary Sachs has published on that.
Yes.
Yeah.
Since then, follow-up studies to that have essentially suggested that the antidepressants provide either no or very modest benefit, but they are great at either causing direct switches into mania or at increasing cycling rates. And consequently, we've looked elsewhere for things to treat bipolar depression, and there are things. There's lithium itself, of course, which is better for mania, but does have antidepressant properties. There's quetiapine, as you mentioned. There's lamotrigine. There's lurasidone, which is frankly much more impressive as a treatment for bipolar depression than it is as an antipsychotic. And also for the anergic bipolar depression, the group at Harvard has found pramipexole to be beneficial.
Yeah, our friend Joe Goldberg has published on that too. There are actually 5 atypical antipsychotics now FDA approved for bipolar depression. And it's interesting that it's only atypical antipsychotics approved for bipolar depression, to your point.
We suspect that's because the ones that are effective, and not all of them, but many of them, the antagonists tend to also be antagonists at 5-HT2A receptors, like trazodone. So that might provide some antidepressant effects. And then
they have various effects.
Yeah, and then you have the partial agonists like aripiprazole and brexpiprazole and cariprazine. Cariprazine in particular looks very promising as a potential treatment for bipolar depression.
Yeah, I agree. I think of the 3, it has this... Yeah, lumateperone's the newest. I think cariprazine has the strongest signal of the 3 as far as antidepressant, and maybe the D3, it may be 5-HT2B antagonism, which is also very prominent. Yeah, it's fascinating to me that the antipsychotics work very similarly with a few exceptions for schizophrenia, but they don't all work the same. They don't all have as potent an antidepressant signal, so it is interesting. And that may be, as you said, the other receptors besides dopamine that they work on. Let's shift gears a little and talk about comorbidity a little bit. You mentioned that a little bit earlier, but when you're seeing these patients, what kinds of comorbidities should we be aware of and thinking about, and how do we manage them?
Big one in schizophrenia spectrum disorder, of course, is comorbid substance use disorders. In our patient population, that runs right around 80%. A little lower in the community, but not all that much lower. And in particular, our patients seem to be drawn to things that are going to be very bad for their brains, such as cannabis during adolescence, cocaine, methamphetamine, things that are going to promote destabilization and progression of their psychosis. I'm in Southern California. And frankly, we are one of the methamphetamine capitals of the world. In fact, when I get a patient and I'm evaluating them, if they tell me they've never used any substances, I'm almost tempted to say, why not get with the program already? Everybody else in Southern California has.
That's funny.
So that's a major. Given the fact that I work in a forensic facility, of course, there are antisocial issues. Very few truly psychopathic individuals, but a number of people who, because of their adverse backgrounds, have grown up and learned some very bad antisocial habits. Also, for those who had a lot of childhood adversity, a borderline personality disorder is very common. Frankly, I don't like that term because I don't believe these people are bordering on anything. I much more like the International Classification of Diseases characterization of it as a mood discontrol disorder, because that intense loss of mood modulation appears to be the core of that disorder. Well, it came out of our psychoanalytic era, in which initially these people were thought to be bordering on schizophrenia because of micropsychotic events.
Yes, events. They were on the borderline of psychosis and neurosis, I think.
Yes, it turns out they have a country all of their own.
That's wonderful. Yeah, it's mood and impulse dysregulation, isn't it? And identity disturbance, frankly, as well.
Yes. Yeah.
Self-harm is a big part of it too, and you find people that don't have schizophrenia diagnoses. It's a little more common in women in the facility where we are compared to men with the more serious psychosis is more male-dominated. So it's a different, and also in our facility, correct me if I'm wrong, it's the civil commitments. We have a few people that have civil commitments as opposed to criminal commitments, and it's people that have this, what do you want to call it, borderline, but it's a type of mood dysregulation, often are not in the criminal justice system.
Very often true. They're often people who've been civilly committed, conserved. And indeed, in those cases, for both our substance use disorders and for many of our personality disordered patients, in addition to treatment of their primary disorder, we use a fair amount of naltrexone. And
I was going to ask about that. Exactly. Yeah.
Because obviously naltrexone has shown benefit in terms of curbing alcohol craving. That's been shown to be helpful for things like kleptomania, trichotillomania, self-injury. And frankly, that describes a lot of the behavioral problems we run into with our patients. We prescribe a great deal of naltrexone in the hospital. And when we do discharge people to the community, to conditional release programs, they often get switched over to the long-acting injectable version of naltrexone, Vivitrol.
Yes, yes. Interesting. So you have found it to be effective, clearly.
Yes. Sometimes people get the idea that people get sent to a state hospital and they go there forever. I'm sitting in a hospital that has 1,600 patients. We discharge about 900 people a year.
Remarkable.
Over half.
And hopefully people in the community are continuing what you were doing, or some common sense in aftercare.
We've really pushed toward educating, part of the group I'm part of, we've pushed toward educating the ConRep physicians and physicians in the community. And frankly, that was another motivation for writing this book, was to get the information to a broader audience.
But there's a bit of a revolving door. It is true. If you don't, we get these people stabilized and they don't have stable housing. And that's also part of this new CARES court and diversion from criminal justice programs where housing is provided, medication is provided, keeps people on path. We still get a lot of our patients that are called IST, incompetent to stand trial. And what happens is that they are on waiting lists to get into the hospital, which is jammed in jails. And it's a horrible place to treat people in general. But what happens is that the median patient, they did a study in our group, has had 14 prior arrests and who is homeless and who has no record in Medicaid or any other database that they've taken medicine for at least 6 months. Our step-down programs are not as good as they are in other countries.
Yeah, that's certainly true. Okay, we're talking about, of course, the benefits of these medications. We need to talk a little bit about managing side effects and risks. And the book has specific guidelines on the management of constipation, which, of course, can be a big problem especially with Clozapine and some of our others, prolactin elevation, and hepatic failure. Could you tell us a little bit about these guidelines?
Yes, you'll find these in particular in the appendices because these are frequently asked questions. For constipation, we typically tell people that anyone you're going to put on a very strongly anticholinergic medication like Clozapine, you want to put them at the very least on a stool softener, usually Docusate, plus very likely an osmotic laxative. Polyethylene glycol is more effective than lactulose. So that's the baseline. You write those orders essentially at the same time you write the Clozapine order. If that's not successful, next step is to add an irritant laxative like a sinucide. If that's not successful, then you may want to get rid of the irritant and go instead for a secretory laxative like linaclotide or pleconatide or lubiprostone. And usually by the time you get to the end of what amounts to an algorithm, you have a person who is no longer constipated. And that's something we encourage people to do. Don't wait for the problem to develop. Intervene early. With prolactin, we spend a lot of time educating physicians to look out for prolactin-related adverse effects such as galactorrhea, amenorrhea, erectile gynecomastia in males. And we also do a lot of time educating them that medications like paliperidone and risperidone are especially prone to raise prolactin because they're excellent substrates for the P glycoprotein pump. So basically, both drugs get pumped right out of the brain and get dumped directly onto the pituitary. And the poor pituitary is sitting there going, why is this stuff dripping on my head?
I want to take a second here, if I could, Michael. Could I just take a second and mention when we talk about fast and slow metabolizers and varying doses, we're usually talking about the cytochrome P450 enzymes, but what I think we don't think about is these other transporters, the PGP family of transporters that can be also genetically variable.
Yes. And people can be either rich with P-glycoprotein or not so rich. The end result is that the cytochrome P450 system and P-glycoprotein transporters combine to determine how much drug is actually floating around in the person, which is another point in favor of actually measuring the amount of drug present.
Exactly. That's what I was getting at. And the PGPs can be at the level of the gut, so they can affect how much is actually getting absorbed and staying there, and then at the level of the blood-brain barrier, so how much is actually staying in the brain. So there's really a couple places.
And then with respect to the liver, often clinicians get very excited about transaminitis, elevation of transaminases, ALT, ALAST. One of the things we point out to them, though, is, yes, that tells you the liver is inflamed, it's irritated. It doesn't tell you how well it's functioning. And it doesn't answer for you the question, should I change how much medication I'm giving the person? The best tool we found for that is the Child-Pugh scale, which was developed for liver transplant patients. And essentially it looks at how much bilirubin is there, how much albumin is there, what's the PT? Does the person have jaundice? Do they have evidence of hepatic encephalopathy? And if those things are present or absent, you get a number of points depending on how abnormal they are. You just add up the points, and then the Child-Pugh scale puts you in one of three categories. Category A, the liver's not happy, but it's functioning, so you don't have to change drug doses. Category B, it's not functioning quite as well as it should be. And for some drugs that have a narrow therapeutic index that are metabolized by the liver, you may need to reduce the dose, maintain the same plasma level. Category C, you really have a failing liver that in some cases you're going to have to stop the drug or you're going to have to reduce it by 80-90%. And one of the things we did in the middle portion of the book where we cite the drugs is we point out which drugs really should be discontinued if the person winds up in Child-Pugh category C.
And I assume that would include some of the anticonvulsants, perhaps?
Yes, some of the anticonvulsants. But some of the antipsychotics, the mood stabilizers in particular, some of the depressants, particularly the older antidepressants like MAO inhibitors and tricyclics.
Yeah, a lot of people don't realize they confuse, since we call the transaminases LFTs, they're not really liver function tests. And as you mentioned, the two best kind of synthetic tests is albumin and the coags, the PT and PT. So at the very least, we should be checking those. And then, of course, the Child-Pugh, I agree, is a good classification scheme. Yeah, of course. Go ahead, please.
I was just going to say, we really owe a thanks to the liver transplant surgeons for coming up with what has become a very useful scale for us. It's often been said that bright people invent things, brilliant people steal.
Yeah, I try to cite my sources, though, as much as possible.
Yes.
Now, it's interesting you mentioned this because many people may have heard that term, the Child-Pugh classification, and it is in the package insert of some of our drugs, but maybe they don't understand what it means. And so this is really helpful to review that. Could we go back for a second to prolactin elevation? I've sometimes seen it done that people will add a low dose of aripiprazole, which is a D2 partial agonist and can lower prolactin. Is that a technique you would recommend?
With some caveats and caution, one thing people need to be aware of with aripiprazole is it has a higher binding affinity for the D2 receptor than any of the dopamine antagonists. Haloperidol and fluphenazine get close, but they're still not quite the same. So it's very easy to begin to displace your primary antipsychotic with aripiprazole if you get the dose above very minimal levels. Because by the time you get aripiprazole up to around 10 milligrams, you're, in most patients, pushing receptor occupancies of greater than 70%, which means your other drug only has 30% of the receptors to work with. And certainly by the time you get aripiprazole up to 15 to 20 milligrams, it's taken over at that point. We also do recommend the other approach that is a bit easier to use for most people is either bromocriptine, which is inconvenient because it's a BID schedule, or pramipexole, which in this context you can use just at bedtime and titrate it up gradually.
These are dopamine. Yeah, these are dopamine agonists, obviously. Yeah,
which so they'll counteract the effect of the D2 blockade at the pituitary, which is what prolactin synthesis and release. People also get very excited sometimes about minor elevations of prolactin. In our own guidelines, we tell people under 100 nanograms per mil, if the person is asymptomatic, is fine. Above 100, you want to bring it down. And above 200, you're really flirting with risk of development of pituitary microadenomas or macroadenoma, perhaps.
Yeah. I had always thought that if it's over 100, you better start at least thinking about other pathologies here and investigate the pituitary a little further.
We tell people if it's over 100 and you do what should decrease it, that is, you decrease the antagonism or you add an agonist and nothing happens, that's when you order an MRI of the cella turcica.
That makes sense. Yeah, dopamine acts as a brake on the release of prolactin, and so obviously antagonists are going to take the foot off the brake, and agonists would put the foot on the brake. Back to aripiprazole. So what about, I see people using 2 or 5 milligrams. Do you think that's reasonable for prolactin?
I think 2 milligrams is fine. 5 milligrams can be fine, but I encourage people to carefully monitor the person's psychosis. And I say that because, frankly, our population is biased very much in favor of positive symptoms. We don't get a lot of people who are predominantly negative symptom psychosis because, frankly, you don't get arrested for sitting quietly and being psychotic. And consequently, for many of our patients, aripiprazole poses a risk of destabilizing them if the dose gets very high. So I'd say 2 milligrams is probably fine. 5, watch carefully.
Yeah, that makes sense. Steve, I want to bring you in here as we get towards the end of our podcast here. I'm just wondering, what do you think the role of the new mechanism of action in antipsychotics is going to be in this population, the muscarinic agonists, the TAR1 agonists?
Okay. God only knows. I don't think this population is going to get them out of therapy with one of these agents, but I do think it's entirely possible that we could practice bad math, where 1 + 1 = 10. So instead of adding, I don't know, not real smart, but my math teacher told me that you couldn't saturate more than 100% of your receptors. So if you give D2 antagonists, 12 of them at super high doses, you don't saturate 300% of D2 receptors. So once you've saturated D2 receptors, that party's over. But if you do a completely different targeting of a place in the psychosis circuit, such as the muscarinic or the 5-HT2 or the trace amines, that they could add to tamping down of the hot spot in dopamine in that circuit. I think early cases probably will get these new drugs as monotherapies, but our cases probably will add them on. And it remains to be seen whether they actually will boost the amount of psychosis relief.
Yeah, and as you know,
we're hopeful because we would like a greater number of mechanisms.
Yeah, and that makes sense. That's that rational polypharmacy, Michael, you were talking about earlier. And as Steve and I know, some of these agents are being studied actively as adjuncts added to other antipsychotics, which I think will be very helpful for us. I'd like to wrap up, if I could here. What would you say is unique about the book, and how can it help clinicians with their patients?
Okay, it is unique because it is targeted at a very difficult patient population. It leads people through a rational approach to evaluating such patients and then to dealing with the common ancillary issues that you run into in treating these complicated patients. In the middle, it provides you with a very rapid, complete access to information about around 85 drugs. Frankly, having done the research on some of the information on some of those drugs, especially the older ones, is devilishly difficult to find because research was not always as good as it is now. But we pulled together as much of it as we could, and each of those middle chapters covers basic characteristics of the drug, mechanism of action, how do you start it, what do you have to do to prep for starting it, what effects should you expect to see, what should you avoid in combination. And then the very last table in each of those chapters are called psychopharmacology pearls. Where does this fit in valuably to the treatment of this kind of patient? And then frankly, the other thing I would encourage people to look at are the appendices. These are the FAQs. These are the questions that come up over and over again, such as, well, if I'm using an MAOI, which is not very common, which foods is it the person has to avoid, or what should they be careful with? So we actually wrote a chapter pointing out how much is contained in various types of food, not with the idea that people can never have these foods, but they need to be careful with them. Under 25 milligrams is not likely to cause problems. Over 100 milligrams, you should probably go see a doctor. And we also include in there a website that people can go to that will identify exactly how much tyramine is in a whole variety of products. The advantage of the website, of course, is that it gets updated on a regular basis. So if you love a particular cheese, you can go look up, see how much is in it, and calculate how much is safe for you to eat.
Sounds like this book is extremely pragmatic, and that may be one of the real benefits and strengths for our colleagues here. Steve, any other final thoughts?
No, really. Just use rationale. You can treat a lot more psychosis than you think with standard doses.
Yeah, I think I like to say common sense is not always common, and this sounds like a common sense approach.
Yes. Yeah, this is indeed a marriage of information derived from both research and practice.
Yeah, and you guys have a lot of experience, a lot of practice with this population. Unfortunately, we've reached the end of the podcast. The time just seemed to fly by. I want to thank you so much, Michael, for sharing this information with us. Thank you for joining us.
Okay, thank you. I enjoyed it.
And Steve, as always, thank you for your wisdom.
Thanks for the great narration and championing this whole thing, Andy.
Sure. I want to thank you all, too, in the audience for listening. And please remember to check out our podcasts in this series, the Psychopharmacology Show. Also, check out all the other NEI podcasts that we have, both CME and non-CME. And for more information on our offerings, please check out our website, www.neiglobal.com. That's neiglobal.com. Thanks until next time.
Thank you so much for joining us for another episode of the NEI Podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today.